Hello, everyone, and welcome to the last and the final part of the lecture on cyst of the jaws and nodal soft tissue. So, as I had promised during the first part of the lecture, in this final part of the lecture is very unique in the sense that I have with me Professor Dr. Kamraj, who would be elaborating on the treatment aspect of cyst of the jaws. All right. So, Professor Dr. Kamraj is the head of oral surgery, and collectively we have worked on this topic. Okay, so in the last two lectures we have discussed about the classification of cyst. We discussed in detail about odontogenic keratocyst and dentigerous cyst, right? So let's move on and actually see what a couple of other cysts that are of importance to you as an undergraduate dental student. So next on the list is lateral periodontal cyst. So this is a developmental cyst. All right, it is again, this is a cyst that arises from the cystic degeneration of dental lamina cells. As the name goes, it arises on the lateral surface of an erupted tooth. All right, the most common tooth that is affected is the mandibular cuspids. It occurs in the adult in adults with a mean age of 50 years, mainly male predilection. And the most important point here is that the associated tooth is vital. Okay, so that is how we actually differentiate lateral periodontal cyst, which is a developmental cyst, as against a radicular cyst, which can also arise on the lateral aspect of a tooth. All right, so a radicular cyst, if it occurs on the lateral aspect of the tooth, radicular cyst is an inflammatory cyst, so the tooth is non-vital, whereas a lateral periodontal cyst is a developmental cyst and the associated tooth is vital. All right, so please remember this and please keep this in mind. This is a very important distinguishing feature. Now, radiographic features: unilocular radiolucent lesions are seen on the lateral surface of a tooth, okay, mainly mandibular cuspids. The size of these radiolucencies is less than 1 centimeter. An example of mandibular cuspid associated unilocular radiolucency. All right. Now, in this case, this tooth is vital, and since it's vital, there's a very high chance that this cyst would be a lateral periodontal cyst. However, if this tooth was actually showing secondary caries here, and this was the radiolucency associated, then this would most probably be radicular cyst. All right. I know radicular cyst is something that I will be discussing ahead, but as part of dental caries and sequelae of dental caries, all of you are already aware of the etiology of radicular caries, radicular cyst, as well as its pathogenesis in general. So now, histopathologically, lateral periodontal cysts are characterized by thin, non-keratinized epithelium, usually 1 to 5 cell layered, and there is something called as focal thickened plaques of proliferating lining projecting into the lumen. All right. So if you look at this white space over here, which is showing this hemorrhagic area, this is the lumen, and this is the content inside the lumen. This dark blue lining is the lining epithelium. Closely, these are the local thickening or the epithelial plaques that are characteristic of the histopathology of lateral periodontal cyst. Okay, now lateral periodontal cysts, developmental cysts, are commonly treated by enucleation. Okay, details will be further explained by Dr. Kamraj in the following. Right, the next important cyst is something called as nasolabial cyst. Previously, it used to be called nasoalveolar cyst or the Klettstad cyst. They commonly occur in the lower anterior part of the nasolacrimal duct. And the clinical features are: there are soft tissue cysts, there's a swelling in the mucobuccal fold and the floor of the nose. Okay, the mean age of occurrence is in the middle age, that is in the age range of 41 to 46 years. And histopathologically, these cysts consist of pseudostratified columnar epithelium with goblet cells. Right. So this is a patient here, and this is the swelling that you notice here, right, in the mucobuccal fold, nasolabial fold, and this is the intraoral swelling that can be seen in the mucobuccal fold. All right. So when excised, when this cyst was excised, this is the histopathological feature, and it clearly shows pseudostratified columnar epithelium with goblet cells. Okay, so this is again a developmental cyst, okay, but is of non-odontogenic origin. Okay, so this is a cyst that is seen in the soft tissue surrounding the oral region. Okay, so moving on to the most important inflammatory cyst, which is radicular cyst. So radicular cyst is also called periapical cyst, apical periodontal cyst, root end cyst. Okay, and it is the most common cyst in the entire orofacial region, right? And the reason why radicular cyst is the most common cyst is because it is inflammatory in origin, and dental caries is the most important cause for initiating radicular cyst. And yeah, it is captured as part of a sequelae of dental caries. That means enamel caries leading on to what happens thereafter, moves into dentine, moves to DEJ, moves into the pulp, then leads to pulpitis, then goes down to the periapex, leading to inflammation of the periapical periodontal fibers, then giving rise to an abscess, granuloma, eventually leading to a cyst, and so on and so forth, right? So pulpal inflammation leads to necrosis, right? And periapical inflammation leading to an abscess, further to a granuloma, and then to a cyst. So this is the pathogenesis. Now, something important when it comes to radicular cyst is the pathogenesis, as well as the theories of expansion of cyst. All right, so I'm going to elaborate on that in due. So clinical features: any teeth. It can affect any teeth because caries can affect any teeth, any age. It's seldom seen in deciduous teeth. In the deciduous dentition, the most common cyst is the dentigerous cyst, right? Whereas in the permanent dentition, the most common cyst is the radicular cyst. Now, the tooth is painful or sensitive to percussion. Okay, sometimes there is acute exacerbation of these lesion as well. Now, radiographically, it's well demarcated, round to oval radiolucency with a sclerotic margin greater than 2 centimeter in the greatest diameter. All right. Now, this radiographic criteria, it helps us to distinguish radiographically between periapical granulomas and periapical cysts. Right. So, if the radiolucency is less than 2 centimeters, then most probably it would be a granuloma. But it's more than 2 centimeters, then it's most probably a radicular cyst. Okay, this cyst rarely leads to root resorption. Okay. Now this is a very good IOPA here, all right, and we're able to see a root stump and associated unilocular radiolucency, all right, which is at least more than 2 centimeter in largest diameter. And the most important thing that you notice is there is a well demarcated sclerotic margin around the around this radiolucency. Now this is most probably a radicular cyst. Now I want to actually explain to you how a radicular cyst actually expands. Okay, now uh, the pathogenesis of a radicular cyst involves basically the inflammatory trigger that actually leads to the proliferation of cell rests of Malleus. Okay, when we talk about cell rests of proliferation and cyst formation, basically what happens is if you have if let's say these are the you know these are the proliferating cell rests of Malleus, then as they proliferate, right, it leads to centralized degeneration of cells in the center, which is because of the fact that as this collection of cells proliferates, the blood supply to the centralmost part becomes lesser and lesser, leading to a central degeneration. This central degeneration actually gives rise to the lumen, right? So when we're talking about the lumen, this is how a lumen of a cyst is formed. All right, Lume and N, right? So this is how a lumen is formed. So this periphery of the lumen has this lining, right? And this is the wall. Okay, so this is the basic anatomy of a cyst. And a cyst basically increases in size by two mechanisms. One is the increase in osmotic pressure in the lumen because of the increase in the cell degeneration, which increases the protein content of the cyst, which in fact causes reverse osmosis, and there is expansion of the cyst that's taking place because of the pressure effect. Okay, the second way the cyst actually expands is because of the action of matrix metalloproteinase, okay, um, which helps in the dissolution of the surrounding bony structure and the expansion of the cyst. All right, so two mechanisms. One is because of the osmotic pressure, reverse osmosis, which increases the intracystic pressure, just causing the expansion of the cyst. And the second mechanism is by the action of the matrix metalloproteinase enzymes on the periphery of the cyst, which cause the resorption of bone and thus expansion of the cyst. Right? Okay, I'm sorry about this diagram that has come out this way, but I believe I've been able to explain if we actually the extract anatomy of the cyst root stump and enucleate the cyst, that means take out the whole cyst in toto, what are we going to find? The histopathology is pretty characteristic for radicular cyst. So radicular cyst has a lining which is non-keratinized lining, epithelium of varying thickness. Okay, it shows an arcading pattern of epithelium because of the inflammation. Right, there is dense inflammation that is seen because obviously caries has triggered this inflammatory response and the formation of the cyst. And we notice something called as cholesterol. This is the arcading pattern of the lining epithelium that is actually seen. So I'll be able to show you this in the case-based learning slides, which right. So this is the lining epithelium, which is actually made up of non-keratinized epithelium, all right, of varying size and thickness, all right, and these are cholesterol clefts. Now cholesterol clefts are basically are indicative of chronic inflammation. Okay, any chronically inflamed lesion can show cholesterol clefts, and cholesterol clefts are formed by the degeneration of RBCs. Okay, right? These are basically empty spaces that are seen in the tissues of chronically inflamed in chronically inflamed tissues where there was cholesterol that had accumulated due to the degeneration of RBCs. Right, now, where has this cholesterol gone? Well, during the tissue processing uh, process, right? When tissue goes through formalin, through alcohol, through xylene, it leads to the dissolution of these cholesterols, and only what we can appreciate is the cleft or the spaces, right? So that is what is cholesterol clefts. So cholesterol clefts are indicative of chronic inflammation, okay, the presence of chronic inflammation, right? Okay, so another important feature that we see in sometimes in radicular cysts is something called as Rushton bodies, and these are linear or curvilinear hyaline bodies, presumably again of hematogenous origin, that are found in the lining epithelium. Okay, so this is also sometimes described as hairpin-like eosinophilic structures in the lining epithelium. So these features are sometimes noted in some periapical lesions, okay, and they help us to triangulate and come up with a diagnosis. So with this, so for most radicular cysts, basically the treatment depends on the size of the cyst. If they are large cysts, then and the tooth can be salvaged, then the root canal treatment is done and denucleation is done. If they are like small cysts, then generally a root canal treatment would be with episectomy would help us in treating these radicular cysts. All right. So move with this. I'm going to pass it on to Dr. Kamraj, who's going to explain the surgical management of the cysts. So he's going to outline on the advantages, disadvantages of both enucleation and marsupialization. So please pay attention. Thank you.
Hi everyone. Now I'm going to talk about the surgical management of cyst. First, we'll see why you want to treat a cyst. As you all know, the cyst keeps on expanding. When the cyst expands, there is a loss of vitality of teeth. There is facial deformation. When cyst grows up, there can be a pathological fracture of bone, and if it compresses on the nerve, it can cause neuropraxia. You need to remove a cyst because there are evidences that it can transform into neoplasm, or there can be neoplastic changes that has been happening, or the cyst can get infected. The principles of managing a cyst is eliminate the lesion, that is, eliminate the cysting along with the cystic lining, cause minimal destruction or damage to surrounding structures like the inferior alveolar nerve in case of lower, and to restore normal function. If the cyst is large enough, then there is reconstruction needed to restore the normal function. So these are the three basic principles when to be borne in mind when you treat a cyst. The surgical management is going to be marsupialization or enucleation. We'll see in detail about marsupialization and enucleation in the next slides. So marsupialization will be either by decompression followed by enucleation. Enucleation can be a primary closure or with open packing. So we'll see what is marsupialization. So marsupialization is just decompressing the cyst. It is called the part 1 procedure. If it is marsupialization followed by enucleation, you got Waldron's procedure, or marsupialization by opening into the nose or into the antrum, which decompresses the cyst if it is in the maxilla. Enucleation is also called as Pasch 2 procedure. Pasch is the one who first did this procedure in 1896, so it is named after him. So enucleation can be removing followed by packing, or enucleation can be with primary closure. Enucleation can be with primary closure or reconstruction if there is going to be a large cyst. So what is marsupialization? Opening is created to decompress the intracystic pressure. How this is done? Elevation of flap, you can see in the picture 1. Then removal of bone. A drill is being used to drill the bone so that the bone is removed. You can see it on the first picture. Then decompressing of the cystic content, you can see in the second picture that the contents of the cyst have been removed. And then suturing the margins. So you can see the margin which is sutured to the lower aspect of the cystic opening. And then the cavity is being packed, because if the empty cavity is being left, there is chances of accumulation of food when you eat and get infected further. The picture on the right shows the sagittal section, how a cyst decompression or a marsupialization is being done. So what are the advantages of marsupialization? It is simple. You can spare vital structures like inferior alveolar nerve in case of the lower, or maxillary antrum in case of upper. It can allow eruption of teeth in future. It will prevent pathological fracture. It reduces operating time and it reduces blood loss, as you are just opening up or just decompressing the cyst alone. The disadvantages: the prolonged healing time. You need to maintain the cavity, so there should be a periodic irrigation of the cavity. The patient has to have a prolonged follow-up visits, which the patient fails to do. So that's the main disadvantage. Regular adjustment of the plug to pack the cavity, or there should be a periodic change of the pack which is given in the cystic cavity. Secondary surgery may be needed if the cyst lining is shrunk to a smaller one, and if there is a risk of new cyst formation, again there should be an enucleation to be done. Talking about enucleation, an opening is created and the whole cyst content is evacuated along with the cystic lining. So it allows for the cystic cavity to be covered by mucoperiosteal flap back to in place, and then the space fills with the blood clot which eventually organize and form normal bone. So you can see in the picture the incision is being made, the flap is being elevated on the picture B, and then the deroofing of bone is done, and then the cyst content is evacuated or removed along with the lining, and then the flap is placed back in the picture E and then suture. This is a clinical picture which shows an enucleation. You can see a cyst in the anterior region on the left side. It has displaced the tooth. So what are the advantages? The advantages are primary closure of the wound, healing is rapid, post-operative care is reduced, thorough examination of the entire cystic lining can be done. The disadvantages are the pulpal necrosis, damage to the adjacent vital structures, more chance of jaw fracture in young persons. The unerupted teeth in the dentary cyst will be removed along with the lesion. So these are the disadvantages of enucleation. Thank you.
Right, thank you, Dr. Kamraj. So for that detailed description on the treatment aspect of cysts. So with this, we come to the end of the topic on cysts of the jaws and soft tissues. And this is some free source links to surgical procedure, enucleation, and marsupialization for your reference. Right. So thank you very much, and please answer the questions on the Google Classroom. Thank you.